Welcome to Dental Sleep in 5, Episode 9. MATRx reports non-responder, but PAP intolerant. Is all hope lost? By way of disclosure, I have no vested interest in any appliance, device, or technology. I maintain a sleep disorders dentistry practice, conduct research, and provide educational programs. Our facility is accredited by the AADSM, and our programs and facility all run to AADSM guidelines. So, CPAP intolerant, can't wear it. MATRx study states not a responder, no point in making an appliance. Is all hope lost? Well, the answer is, hell no. For some patients, as you've heard me mention before, an oral appliance is the complete journey, and for others, an oral appliance is the beginning of the journey. Watch Dental Sleep in 5 Episode 1 to learn more about adjunctive therapies, which is what I'm talking about. For incomplete responders, the MATRx Plus actually provides insights as to whether it may still be worthwhile to proceed with an oral appliance. And this is a big yes in helping the patient. So the MATRx Plus system, over-the-counter trays that you fit chair-side, you determine the patient range of motion, protrusively, retrusively, and by remote control and Bluetooth, this device will advance the jaw and retrude the jaw, and in a systematic manner evaluate oxygen desaturation index, respiration, and so forth. The MATRx algorithm was developed using a random forest machine learning to evaluate binary outcomes for 266 different features. Now, each of these decision trees are either a yay or a nay for oral appliance, and this information is used along with the treatment outcomes on the static, which is the final night of the test, to predict both therapeutic success, whether they will respond to oral appliance therapy, and optimum position. Now, as Zephyr is continuously working on improving their algorithm, the number of variables is likely higher now. The original validation study used these 266 features. So, on the TherAgnostic Study, which is a multi-night study, the first night, the system will respond to respiratory events by protruding the mandible and 0.2 millimeter steps and moving throughout the patient's mandibular range of motion, looking for the spot, if you will. On the second night, they beeline to that spot and then fine-tune from there. And sometimes a third night is requested. In the end, there's 8 scalable channels with 10-second to 8-hour windows. So we're looking at sensor status, mandibular protrusion, oxygen saturation, airflow, heart rate, respiratory effort, snoring, and body position. Labeled a responder, you can proceed with confidence. In their validation study, they got it right 67 out of 69 times, and that they labeled them a responder, and they brought the ODI down to less than 10 with their custom appliance. And 2 failures, they didn't quite make it to below 10. But in the clinical world, those 2 would have still been helped satisfactorily. So you can proceed with confidence if they're labeled a responder, in that desaturations will normalize, and they'll also provide you insight with regards to optimum protrusion. So let's take a look at this patient here that presented with 139 events per hour. You've seen this before in another Dental Sleep in 5. Supine 171, non-supine 118. He asked me, is an oral appliance going to work for me? Well, how can I answer this and sleep at night? So I said, let's do a MATRx Plus test, and it labeled him a responder. Of course, he had to wear his appliance at 95% of his protrusive range, but he tolerated the trays, so we felt he would be okay. And it took a couple months for him to acclimatize to that position comfortably in his custom appliance. But when I sent him home with an HST, the first one demonstrated this result. And after rubbing my eyes, he said, take this home again, do 2 consecutive nights. So he did 2 other consecutive nights, and you can see, it doesn't matter what position he was sleeping in, he was under 5 in all of these studies. So there's 3 NOx T3 HSTs. that demonstrated complete resolution of his original problem. So I sent the report off to the sleep specialist showing his original indexes and the index in all positions wearing the appliance. Now, if the patient's labeled a non-responder, this is where it may become problematic if you're dealing with a PAP intolerant patient. Sure, if you're evaluating somebody off the street and they could go PAP or they could go oral appliance, great. You don't seem to be responding to oral appliance therapy according to this test, go try PAP. But, in my world in Ontario, almost everybody gets to try PAP before I get a chance with an oral appliance. So most of the time I'm dealing with PAP intolerant people that are refusing to use PAP or genuinely cannot use it. So let's take a look at why I'm saying this might be a problem. You have 9 predicted failures that were actually responders when the appliance was made. So they got it wrong. And what about those folks that actually benefited enough, they had enough of a clinical benefit, but didn't get down into the range they wanted to get them to, below 10 ODI, but using adjunctive therapies along with the appliance, they may be helped. If they're PAP intolerant, it would be nice to get some insight as to who these folks are. So, there's good news. Meaningful information can be obtained in the final static report, and when compared to baseline data, can provide insight as to whether the patient will respond enough to proceed with an oral appliance. Look at the raw data on the final static study, review the ODI, oxygen desaturation index, body position, and determine, is the ODI improved from baseline? Is the ODI related to the sleep position? Is the ODI in clusters, perhaps REM related? So let's take a look at this one patient that was labeled a non-responder. His baseline AHI 55.2. So ODI on his static test, the last test of the TherAgnostic series, 50. Didn't really help much. Well, if we look in supine, 60.1, look in non-supine, 51, there didn't seem to be any clustering indicating REM related. So, when you look at this raw data, there's no point in wasting your time and their time with an oral appliance. This individual is likely not to respond to mandibular advancement. I don't see any signs here at all that making him an appliance is going to put him in a better place. So let's look at this non-responder. Original baseline 73.9. Overall ODI brought him down to 16.4. Well, that's an improvement, but it's a failed study. 16.4 is really not acceptable. However, in supine position, 53.9, and in non-supine, 9.3. Is this an individual I would go ahead and make an appliance for? Absolutely. Taking into consideration adjunctive positional therapy along with the appliance, I think we could end up with a good result. Now, of course, it's never a guarantee. You're not going to guarantee the patient that, but you're using some meaningful data that you can share with the patient and say, well, from what I see here, this is likely to happen. Now, in this individual, 52.3 is baseline, overall ODI 11.3. Now, when we look, non-REM, 6.9. Clearly, this was the beginning of the study. It was not into REM sleep for a while. And how do I know that I'll be looking at REM at these following charts? Well, they're in clusters through the night. Only explanation I have for this is that this is REM-related apnea. And if you have their baseline study, you can refer back to their baseline study to see if you see a similar pattern. Just, this is a guess, but it makes sense from the knowledge we have about the way this stuff works. And you can have a baseline view to take a look and see how it compares. And if you see a similar pattern, you can be pretty certain that you're looking at REM versus non-REM sleep. So the significance of REM OSA, of course, still remains controversial in the literature. There's people on both sides of the fence. However, Severe REM OSA seems to be associated with cardiovascular endpoints in those that have prevalent cardiovascular disease, and REM OSA is quite prevalent and associated with adverse cardiovascular and metabolic outcomes. So you need to take REM-related apnea seriously, even though there's arguments on both sides of the fence as to its relevance. You can't ignore it and say it's not important. Well, what we know is 1/3 of PAP patients wear their PAP all night long, and that's great. Because as we know, through the sleep period, the amount of time spent in REM sleep increases. So those patients are managing their airway. But the ones that are taking off partway through the night, after 2 hours, after 3 hours, are not wearing their PAP when they're needing it most. So for non-compliant PAP users, it's kind of a no-brainer. I would proceed with an oral appliance. If they are semi-compliant PAP users, well, an oral appliance may be equal to PAP if you really could analyze whether them wearing PAP during the early part of the sleep period and not wearing it when they need it most during REM, and compare it to the benefit they're getting with wearing their appliance all night long, probably not going to be much difference. But even better yet is combining the notion of combining the oral appliance with their PAP so that they can wear their positive airway pressure at a lower level and perhaps be able to tolerate wearing it all night long. Now you've really helped the individual, giving them something they can actually use. So it doesn't have to be either PAP or an oral appliance. Sometimes combining the two for this particular individual is the way to go. So some caveats: night-to-night variability. This happens with HST, it happens in lab, and it's going to happen with this test also. So reviewing this raw data does not predict that the oximetry on another night will be what it says here. We need to keep that in mind. The MATRx prediction uses machine learning that evaluates 266 binary variables along with ODI. It's a highly intelligent algorithm. So we can't compare what we're doing here using this off-label with that assessment. What we're looking at is, okay, it failed the criteria of bringing that ODI below 10 and the random learning criteria, but are those people that are close enough that we can help them still with an oral appliance with adjunctive therapy? Now, you can evaluate things further. You can solidify the MATRx trays with what they call a TD clip and have the patient wear it, assess things subjectively by asking them questions, send them home with an HST over a couple of nights and evaluate things further. If you really want to do that level of evaluation before proceeding with an appliance based on the raw data. We can use this, I'm going to say, off-label assessment to establish partial responders that could benefit from an oral appliance, especially for those patients that have failed using PAP. So, the MATRx Plus is very useful to verify response to oral appliance therapy. No reason to discount oral appliance therapy due to severity, which physicians do all the time. Test and find out, will the patient respond to oral appliance therapy? Doesn't matter, 100, 120, 150, I don't care. If you want to know the patient's a candidate dentally, TMJ-wise, muscles are comfortable, they can tolerate wearing an appliance, well, then it's worthwhile evaluating to see whether an appliance will help them at all, or enough, or completely. For non-responders, well, view the raw data to determine improvements from baseline. Establish positional component. Establish REM-related component. Consider the potential of use of adjunctive therapies along with the oral appliance, and consider the potential of combining PAP along with the oral appliance. Okay? Especially important for PAP intolerant patients. It's so unfortunate, so many people falling through the cracks, having been told about PAP, having been discouraged from even considering an oral appliance, and when they can't tolerate wearing PAP, just sit in limbo unmanaged. Should be criminal. We can best help our patients by working together. PAP is great if you can comfortably wear it all night long and comply with that. But if you can't, then it is definitely worthwhile looking into an oral appliance alternative. We can test up front to see if it'll work, and we can even find out if you're going to get enough help that it's worthwhile pursuing and using it along with adjunctive therapies to take you the rest of the way. And sometimes the best answer is just simply wearing PAP and the oral appliance together. I've taken care of a number of patients that way, and I know of some clinicians that use that routinely across North America. So it is definitely doable, and for some cases, that's really the only way they're going to get the help they need. Hopefully, this helps to put another spin on the use of this wonderful product, the MATRx Plus, so that you can get information to better help your patients in your practice. Thank you, and sweet dreams.